Well, greetings, one and all. My name is Karen Dick.
And I am Ganesan Abu. Together we hope to guide you through the new Southern Health Santé Sud Sepsis Caremap.
Well, Ganesan, would you like to be able to explain to us why we need a new guideline?
The 2016 Surviving Sepsis Guidelines has many changes regarding definitions, screening, and management. Our objectives are to help you integrate these new guidelines into practice.
So, why do we need new definitions for sepsis?
It's been 20 years since this has been reviewed. A definition should describe what something is. Until now, the definition of sepsis has relied on the clinical criteria of systemic inflammatory response syndrome.
Now, SIRS has been long used by us. What's wrong with using SIRS?
Well, for the definition, we need something that described what the condition was. And if I told you that it waddled along and quacked, you would immediately recognize that I was referring to a duck. But a patient with infection, high fever, and a raised white cell count does not differentiate between a normal response to infection and sepsis.
Ah, so that means SIRS is no longer part of the definition.
That is correct, because SIRS is based on clinical criteria. And apart from its other shortcomings, it's not really relevant to the definition.
So, Ganesan, can you explain to us how sepsis is defined now?
Well, there are four components to the definition. We know that sepsis is triggered by infection, and this is not a normal response to infection. We say that this is dysregulated. The hallmark of sepsis is organ dysfunction, and this is what makes it life-threatening. So we can summarize the definition of sepsis as life-threatening organ dysfunction that is caused by a dysregulated host response to infection.
So, previously we had SIRS, we had sepsis, we had severe sepsis, and then we had septic shock. Do the definitions cater for this?
This falsely suggests an orderly progression, like the ducks, from SIRS to septic shock. However, we know that patients can rapidly transition from infection straight to septic shock.
That's true. We've seen that. How would you define septic shock?
Those who developed the new definitions struggled with this because they could not use clinical criteria in the definition. The best they could come up with was that septic shock was a subset of sepsis which had a greater risk of dying.
Oh, so then what happens to the severe sepsis category?
The old severe sepsis category depended on organ dysfunction. We are now defining sepsis on the basis of organ dysfunction. So really there's no need for a separate category. This also highlights the fact that all sepsis is severe. So there really is no such thing as mild sepsis.
So, Ganesan, you were saying that the screening tools have changed. Can you tell us about the screening tools that have been evaluated?
Unfortunately, we do not have a perfect screening tool, nor a perfect diagnostic test. Now, some of the screening tools that were evaluated were SIRS, SOFA, QSOFA, and NEWS, but none of these have been prospectively validated.
So then what did we decide to go with?
We went with NEWS.
And why did we omit the SIRS?
I alluded to some of this earlier, but it's too non-specific. It suggests a stepwise process, and it places too much emphasis on inflammation. And we know that there are anti-inflammatory processes at play as well.
Goodness, and this news category screening tools sounds very interesting. Can you tell us more about it?
Well, NEWS stands for New Early Warning System. It's a British system that appears to have had success in the UK and was found to be superior to SOFA in a study out of Chicago.
And can you describe for us how it works?
Well, the scoring tool uses 7 clinical criteria, and an easy way to remember them is to combine the organ systems. Uh, so, level of consciousness and temperature, heart rate and systolic blood pressure, respiratory rate, oxygen saturation, and the need for supplemental oxygen. A combined score of 5 or more does not diagnose sepsis but suggests a very sick patient and acts as a trigger for considering sepsis.
This news score sounds like an excellent screening tool that maybe we should also consider using on the wards to track our vital signs.
Absolutely. Instead of passively recording vital signs, NEWS acts as an early warning system and would alert one if a patient were deteriorating.
So, you mentioned earlier that criteria for septic shock could not be part of the definition. Has the criteria changed though?
The new definition of septic shock has been tightened up to reflect the sickest of the patients with sepsis. There are 3 factors. Firstly, hypotension that persists despite adequate fluid resuscitation.
And what does adequate mean?
20 to 30 mLs per kilogram of crystalloid in the first 3 hours would be considered adequate fluid resuscitation.
And I guess hypotension is still defined as a mean arterial pressure of less than 65?
That is correct. The second factor is the need to use vasopressors. The last factor is the big change and considers a lactate of greater than 2. And this has to be taken 3 hours after fluid resuscitation started.
And why should we be waiting 3 hours?
Fluids alone and early antibiotics can help reduce those factors that trigger and sustain the septic process. By checking a marker of severity at the 3-hour mark, we can see which way we are trending.
This is still confusing. Can you use an example to explain it to us?
Let's consider this patient with sepsis with a mean arterial pressure of 65 and a lactate of 3.8 initially. After 3 hours of fluid resuscitation and antibiotics, the patient now needs vasopressors to maintain blood pressure. The mean arterial pressure now is 55, but the lactate is only 1.8. Therefore, this patient does not have sepsis. However, this is still a very sick patient.
Absolutely. Which would then put them at an even higher risk of dying?
Correct.
So now let's take a closer look at this new care map. How is it different from the previous one?
The care map is now only 2 pages as compared to the old 8-page document. We decided to concentrate on the first 60 minutes of care, as this is what is critical to the final outcome. It is intended for point of care use in all acute situations. That means the emergency room, general wards, and the ICU.
So let's take you through this care map using a case study. We have Mrs. Z, who is a 52-year-old gal who presents to the emergency department with lower abdominal pain. She has a fever, confusion, and foul-smelling urine. Examination reveals a temperature of 36, her heart rate is 118, her blood pressure is 90 on 50 with a mean arterial pressure of 60, and her Glasgow Coma score is 13. Would you say that she has sepsis?
Let's start by looking at when and how we should use the new screening tool. One has to always have a high degree of suspicion for sepsis, in all patients who are very sick, whatever the cause. First, we should apply the NEWS tool. For those patients who score 5 or above, one has to actively investigate for organ dysfunction. If there is evidence of dysfunction in 2 or more organ systems, then we can make the diagnosis of sepsis. While we're doing this, we have to recognize the importance of simultaneous resuscitation together with our evaluation.
Now I notice that the document has time goals.
The red arrows in the second column point to the time goals. The purple arrows show the intervention times, and it is important that you fill this out as this helps us to continue to give quality care.
Could you go over the goals that are highlighted in the first 10 minutes?
Within the first 10 minutes, we need to administer the NEWS tool and start resuscitation with crystalloid fluids.
What should the nurse do if the NEWS score is 5 or more?
The nurse should immediately inform the attending physician, start an IV, and move the patient to the best area to administer care.
And what does that mean?
For the emergency room, it may mean placing the patient in the resuscitation area. For the patient on the general ward, it may mean calling a code 25 and transferring the patient down to the emergency room or ICU. And for non-regional sites, that may mean consulting and transferring the patient to a regional center.
So EDIS still uses the SIRS criteria. How should we proceed?
Ideally, EDIS should include whatever the province ultimately decides is the best screening tool. For now, I would advise that if the patient meets SIRS criteria, then use the NEWS tool to fine-tune and go by what the NEWS score informs. Feel welcome to use the NEWS score up front as well.
In the early days of sepsis management, we used to say, fill the tank first and then squeeze the blood vessels. It wasn't uncommon for us to use between 6 and 8 liters of fluid. The Caremap now is very careful to limit excessive fluids.
The evidence is against excessive fluid because all the extra fluid ends up in the wrong place. We want to give only fluid such that it contributes to an increase in stroke volume. When more fluid does not improve stroke volume, then it's time to stop. We start with small boluses and look for a response after 30 minutes.
So what is so magical about the 30 minutes?
Because this is how long it takes for the fluid to circulate through all the fluid compartments.
So how do we know when to stop or to cut back?
The best way is to use non-invasive cardiac output monitoring and to do the leg raising test. But we don't have that equipment. So I would suggest look for improvement in clinical parameters, such as an increase in mean arterial pressure, a reduction in the heart rate, a reduction in the pulse pressure, and an increase in urine output.
So what are your thoughts about putting in a central line to figure out our central venous pressure?
Central venous pressure is a very poor marker of left ventricular end diastolic volume and stroke volume. We want to avoid unnecessary invasive interventions. A central line may be required later, to administer vasopressors long term, for example, but really there's no hurry right now.
So you're saying it's okay to start vasopressors together with fluids early on and through a peripheral line?
Yes, this may limit the amount of fluid used, and it's okay to use the peripheral line for a few hours.
And I also happen to notice that the vasopressor order comes in early at the 10-minute mark.
You will notice that this is an open box, and it's put here merely to underline the concept that it can be used early if required. I would think you'd still be giving fluids at the 10-minute mark.
So, overlapping the 10 to 30-minute goals are also some investigations.
Yes, for those patients with new score more than 5, we need to do two things. Firstly, we have to confirm organ dysfunction with additional laboratory tests. And secondly, we have to actively seek the source of an infection. For a diagnosis of sepsis, we need to show dysfunction in at least two organ systems, such as reduced level of consciousness, low mean arterial pressure, low oxygen saturation, and elevated creatinine, or reduced urine output, and elevated INR, or reduced platelet count.
Now, our non regional sites don't have the ability to have bilirubins done in their labs. Is this a problem?
In large database studies, bilirubin was more commonly done, and therefore it was included. However, INR is the more sensitive indicator of liver dysfunction, so INR alone is okay.
So, what would be our goals at the 30-minute mark?
By the 30-minute mark, we would expect many of our results to be back so that we can confirm organ dysfunction and a diagnosis of sepsis. It is clear that Mrs. Z does have sepsis, but we're well on our way to simultaneously resuscitating her.
And speaking of Mrs. Z, Halby, let's get back to our case. So, at the 60-minute mark, Mrs. Z has now received 1 liter of Ringer's lactate, and her examination reveals that she has a temperature of 36.2, her heart rate has climbed a little to 122, and her respiratory rate to 26, and her blood pressure has graced us with a level of 80 on 40, with a mean arterial pressure of 53, and her Glasgow Coma score remains at 13. On the surface, it would appear as though Mrs. Z has septic shock.
We cannot make a determination of septic shock before the 3-hour mark. An initial lactate level of 3.6 does not confirm septic shock, despite ongoing hypotension and the use of vasopressors.
So now let's talk about antibiotics. We should administer antibiotics within the 60-minute mark and choose broad spectrum drugs.
Correct. We should not delay antibiotics, and ideally start them as soon as possible once the cultures are drawn. If for any reason the cultures cannot be drawn timeously, then we should give the antibiotic and take cultures as soon as possible. Early antibiotics reduce the likely trigger of the septic process.
Now, getting back to Mrs. Z, at the 180-minute mark, she is now in ICU and she has received 2 liters of Ringer's lactate. The norepi has been infusing via a peripheral line, and her temperature is 36.6. Her heart rate is down to 104, her respiratory rate down to 22, her MAP has climbed a bit to 60, and her GCS is up to 14. Her repeat lactate at this 180 mark is also 1.8. So she actually seems to be getting better, but still needs norepi.
Yes, she does appear to be improving.
I noticed that dopamine is not part of this care map.
Dopamine causes tachycardia and is arrhythmogenic and can lead to worse outcomes. Norepinephrine is the vasopressor of choice, and if needed, either epinephrine or vasopressin can be added.
So, what are the most important goals at the 3-hour mark?
Resuscitation progresses such that at least 20 to 30 mLs per kilogram of crystalloid should now be completed. It is also important to recheck the lactate to determine if she's in septic shock.
Is she in septic shock?
Well, let's see if she meets the criteria. Her mean arterial pressure is less than 65, so she's hypotensive. She's on a vasopressor, but her 3-hour lactate is less than 2, so she's not in septic shock. However, Mrs. Z is still a very sick lady.
Well, this brings us to the end. Is it possible to review this video at home?
Yes, smartabx.ca is the link to our website, and the video is easily accessible there.
I'd like to thank you so much, Ganesan, for your time and your expertise.
Well, thank you, Karen, and it's been great doing this.